Hello everyone, welcome back to my channel. Today we are going to discuss a very important topic, that is infertility. Okay, the both male and female infertility. So let's start. First, coming to the definition of infertility. What is the definition? It is the failure of a couple to conceive even after 1 year of regular intercourse without contraception, and this is in the reproductive age group. Okay, in the reproductive age group. Then what is primary infertility and what is secondary infertility? Primary infertility means patient has not or never been pregnant before, and what is secondary infertility? That patient has been pregnant before, but now due to some reasons she is not able to conceive. So what is primary? Never been pregnant, and secondary is one or more pregnancy. It may be abortion also, but now not able to conceive. There are two important terms related to infertility that will be asked in the viva, that is fecundability and fecundity. So what is the difference? See, this is the probability of achieving a live. So this is the probability of achieving pregnancy within one menstrual cycle. And fecundity is, it is the probability of achieving a live pregnancy. So this is the difference. This is the only difference. See, this is only achieving pregnancy, and fecundity is probability of achieving live pregnancy in one menstrual cycle. Okay, so this is the difference. This is live pregnancy and this is only achieving a pregnancy. Then coming to female infertility. So how to do the basic evaluation of an infertile couple? Okay, first coming to the history. Okay, first what are the investigations we will do, how we will take the history, what are the examinations we will do, all the investigations, how to evaluate a female as well as a male, everything will be discussed. Okay, so then first coming to the evaluation of infertile couple, first we take history and examination. Okay, then semen analysis and tests of ovulation, ovarian reserve and tubal patency. These all things needs to be normal so that a normal pregnancy can occur. So coming to the history, first we need to know, see in history what we will ask. We'll ask the patient about age. Age is important because in early or in elderly primary there is decreased chances of conceiving because the ovarian reserve is decreased. So age is important. Then coming to menstrual cycle. We need to take history about menstrual cycle. What? The regularity is important. Why? Because regular cycles are ovulatory and irregular cycles are anovulatory. So there is decreased chances of pregnancy in case of irregular cycles or anovulatory cycles. Then coming to the amount of bleeding. Here also we need to know that if the amount is heavy in a menstrual cycle, if she is complaining of heavy menstrual cycle, then it may be due to submucous fibroid or polyp that will prevent the implantation of the embryo. Okay, then coming to dysmenorrhea, we will take the history of dysmenorrhea, that is pain during menstruation. Why? Because dysmenorrhea is associated with endometriosis. Okay, so in endometriosis, what happens due to diffuse adhesions or infection? Diffuse adhesion, what happens? There is distorted anatomy. The tubes and uterus, the anatomy is distorted. So the normal fertilization could not occur. The ova cannot come to the fallopian tube as well as the sperm cannot ascend. So due to the diffuse adhesions and distorted anatomy, due to endometriosis, there occurs dysmenorrhea. So by taking the history of dysmenorrhea, we can rule out the endometriosis. Then what we need to know about dyspareunia? History about pelvic pain or history of genital tuberculosis, because these also leads to infertility. Okay, then coming to the female causes. See, female causes, what we know that female reproductive organs consist of ovary, fallopian tubes, uterus and the outflow tract. So any of the problem, or if any of these is having problem, then it can lead to infertility. So first is ovarian causes, then tubal causes, then uterine causes, and fourth is unexplained. Most common is ovarian causes, and most common ovarian cause is anovulation. So if the ovary is affected, it can lead to, see, ovarian causes may be first due to anovulation. I've told you anovulation is most common, and it may be due to anovulation or if there is decreased ovarian reserve. Decreased ovarian reserve means ovarian reserve is decreased. What is ovarian reserve? Reserve means reserve of oocytes. So the ova. If the ova is decreased ova, okay, due to age or any other factors, then that leads to decreased ovarian reserve and that leads to ovarian cause of infertility. Then coming to the ovarian causes. First, due to anovulation, and second due to decreased ovarian reserve. So what are the tests for anovulation? What we need to do? so that we can detect that there is no ovulation, or if there is ovulation. Okay, what are the tests for ovulation? For normal ovulation, the tests are: first, basal body temperature. In normal ovarian cycle, in normal ovulatory cycle, okay, what happens? Due to ovulation, there is increased progesterone. So that leads to increase in basal body temperature by 0.5 to 1 degree. So there is rise of temperature by 0.5 to 1 degree after ovulation due to the effect of progesterone. So if the temperature rises in the mid cycle, that means the cycle is ovulatory. Okay, and if it doesn't, so it may be anovulatory, which is a cause of anovulation or infertility. Then second is furning pattern. Furning pattern in vaginal cytology. What we see in the vaginal cytology? See, furning pattern, furning or spin bucket or stretchability. That means the cervical mucus is stretchable due to the effect of estrogen. And in vaginal cytology, on the smear, if we see in the microscope, there is furning pattern like this. Okay, there is furning pattern. So that is due to the effect of estrogen. That means if in the proliferative phase of the endometrial cycle, that means, see, furning or spin bucket or stretchability is due to estrogen. So will that be present in the luteal phase? No, that will not be present in the luteal phase. That is, furning or spin bucket or stretchability will be reduced in luteal phase if there is presence of progesterone. But if the stretchability or spin bucket or furning pattern is present even after the day 14 of the cycle, or even in the luteal phase, if it is present in the second half of the cycle, that means there is no progesterone. If there is no progesterone, that means no ovulation has occurred. So if there is persistence of furning in second half of cycle, that means anovulatory. Okay, that is beyond 22nd day of menstrual cycle, day 22. Even in day 22, if there is presence of furning, that is anovulatory cycle. Okay, then coming to the WHO classification of the ovarian causes. Before that, I will tell other important factor, see, to determine the anovulation. What happens? We do in vaginal cytology, what we see, if this is the normal vaginal epithelium, there are three layers in the epithelium. First, this is the basal layer, this is the intermediate layer, and above it is the superficial layer. Superficial layer is predominantly estrogen dependent. Superficial layer. So this is estrogen dependent, and intermediate is progesterone dependent. So in the second half of the cycle, if there is abundant amount of intermediate cells, that means the cycle is ovulatory. So if the patient is ovulating, that means there is more progesterone and there is more amount of intermediate cells. So if the patient is ovulating, there is more progesterone and more intermediate cells in the vaginal cytology. Okay, then coming to the endometrial biopsy. In endometrial biopsy, what we see, I've told you in the menstrual cycle, in the endometrial biopsy, in the second half of the cycle after ovulation, there is presence of secretory endometrium or corkscrew appearance of the glands or subnuclear vacuolation as well as stromal edema in day 22. That is, in maximum at day 22, there is maximum stromal edema. So, we see presence of secretory endometrium. What are the features of secretory endometrium? First, subnuclear vacuoles, corkscrew glands or tortuous glands, and stromal edema, which is maximum in day 22 of the cycle. Okay, understood? Then the most important is the hormonal study. What hormones we see? We see the serum progesterone. Serum progesterone. If the cycle is ovulatory, serum progesterone will increase from 1 nanogram, less than 1 nanogram at day 3 of the menstrual cycle to more than 3 nanogram per ml in day 22 of the cycle, which is diagnostic of ovulation. Okay. Okay, so now if there is ovulation, there is more than 3 nanogram per ml level of serum progesterone. Then coming to the so what is the best test? Best test to detect ovulation is the hormonal study, that is serum progesterone at day 22. And what is the best test to predict ovulation? That means that ovulation will occur or not. That means there will be increased level of LH. So LH kits are available that will show increased amount of LH. That is the best test to predict the ovulation. So LH kits is the best test to predict the ovulation. See what happens. First there occurs LH surge, then there occurs LH peak. I've told you in the menstrual cycle, then there occurs ovulation. What is the time between LH surge to ovulation? It is 32 to 36 hours. Okay. Then from LH peak to ovulation is 10 to 12 hours. This you have to remember. Okay. So what are the tests? How we will do the LH? We will take time to do the LH test is the late afternoon. In the late afternoon, that is from 4 p.m. to 10 p.m. from 4 p.m. to 10 p.m. And once the test is positive, that means ovulation has occurred. Once the ovulation test is positive, that means ovulation has occurred. So advise intercourse. Okay, this is the treatment. This is the importance that if we know that there is LH surge or there is LH is present and the ovulation has occurred, so we can advise the intercourse. And then what is the management of anovulation? We will give oral ovulations or ovulation inducing drugs. Management of anovulation is ovulation ovulation inducing drugs. What are the ovulation inducing drugs? First, clomiphene citrate. Second is the letrozole. These are the first line. It is selective estrogen receptor modulator and letrozole is aromatase inhibitor. Then we can give second line, that is HMG or GnRH analogs like leuprolide, or we can give HCG, that is similar to LH, that helps in LH like LH surge and ovulation. Okay, so this is the ovulation inducing drugs. So what is the difference? See, this one is the first line and this is the second line. This is the GnRH analogs are the third line drugs. First we will try with clomiphene citrate or letrozole. Okay, then what is the difference between clomiphene citrate and letrozole? See, this is the selective mechanism of action is selective estrogen receptor modulator. Letrozole is aromatase inhibitor. What is the T-half? T-half is 5 to 7 days. But here it has short T-half, that is 45 hours only. And is there any anti-estrogenic effect? Yes, there is anti-estrogenic effect by the clomiphene citrate. So this causes thin endometrium. Before, clomiphene citrate was the drug of choice for ovulation inducing agent, but now it has changed to letrozole. It is the first line or drug of choice for ovulation induction, both in normal as well as the PCOS patients. Okay. And also because clomiphene citrate was doing thin endometrium and altered cervical mucus, altered cervical mucus. But letrozole, what it had, it causes, as it has no anti-estrogenic effect, so it causes thick endometrium, and favorable cervical mucus that help to penetrate the sperm as well as for implantation. Okay. And what about the uterine flow? Yes, it decreases the uterine blood flow as well as the letrozole increases the uterine blood flow. So again, it is a positive factor or an advantage of the letrozole from the clomiphene citrate. Okay. Then what is the ovulation rate? Ovulation rate is 60 to 85% in clomiphene citrate as well as 70 to 80% in letrozole. What is the pregnancy rate? It is 10 to 12% in per cycle, 10 to 12%, as well as 10 to 15% per cycle in letrozole. So chances of multiple pregnancy is high in clomiphene citrate as well as low in letrozole. And chances of OHSS is high in clomiphene citrate. Okay. What is OHSS? That is ovarian hyperstimulation syndrome. If we give ovulation induction agent, if more number of ovarian follicles are stimulated, that may cause ovarian hyperstimulation syndrome. That is a side effect of clomiphene citrate, which is very, very low in case of letrozole. So that is another advantage why we use the letrozole as a drug of choice in ovulation induction. Okay, then coming to the how we will know in ultrasound that ovulation has occurred. This one by the hormonal test and vaginal cytology as well as endometrial biopsy. We are able to know by the basal body temperature. But what are the ultrasound features of ovulation? In ultrasound, we will see the size of the follicle. Okay, this is by serial ultrasound we will see. Okay, in alternate day, first there will be increase in 2 to 3 mm per day till 18 to 20 mm, then there will be decreasing size and there will be fluid in pouch of Douglas. Fluid in pouch of Douglas and endometrium will be triple layered. Triple layered or trilaminar. Trilaminar due to the effect of progesterone. Okay, trilaminar due to progesterone. So these are the ultrasound features of ultrasound signs of ovulation. Okay, then coming to the second part. So this was the test for ovulation. Okay, or we can detect if there is ovulation has occurred or if the cycle is anovulatory. Then what are the tests for ovarian reserve? For ovarian reserve, the first test is serum FSH. I've told you in menopause that if the serum FSH level is more than 40 international unit per ml in day 3 of the menstrual cycle, that means premature ovarian failure. Okay, premature ovarian failure. That is diagnostic of premature ovarian insufficiency. Okay, and if the level is more than 20 international unit, then that is suggestive of, not diagnostic, that is suggestive of primary ovarian insufficiency. And if more than equal to 15 international unit, that means poor ovarian reserve. Okay, then coming to the second test, that is serum inhibin. What happens to serum inhibin B? As there is, see, serum inhibin B is secreted by the follicles. So if there is poor ovarian reserve, that means there are no follicles or decreased follicles. That means the inhibin B level will be decreased. Okay, so what is the level? As there is no follicle, the inhibin level will be decreased. So less than 45 picogram per ml is on day 3 of the mens is diagnostic. Okay. Then coming to the clomiphene citrate challenge test. Clomiphene citrate challenge test. What we do? First, we take the day 3 level of FSH. Then we measure the day 3 level of the FSH. Then what we do? We give clomiphene citrate to the patient. What is the dose? Dose is 100 milligram. On what day we will give? From day 5 to day 9. Okay, then what will happen? We will again measure day 10 FSH. That will be increased. If there is increased level of FSH from day 3 to day 9, so that means increase in poor, see, FSH level increases in poor ovarian reserve patient, because we give clomiphene citrate and the ovary is stimulated, but it does not secrete estrogen or progesterone. Okay, that is ovarian failure. So FSH level will be increased more, but there will be no effect on ovary because ovary has failed. Then coming to the third, that is serum AMH level. Serum AMH is anti-Mullerian hormone. This is the best test. Okay, this one is the best test, and we can do in any day of the cycle. Not only day 3, any day of the cycle we can do, we can measure. Okay. Then another is the antral follicle count. What is antral follicle? These are the follicles that are present in the ovary. So we see this by ultrasound. We will count how much follicles are present. So antral follicle count will be low in case of poor ovarian reserve. Okay. How we'll do? We'll do by TVS. Okay. By transvaginal ultrasound, transvaginal sonography, we will see the antral follicle count. We will measure, and antral follicle count, if more than 6 in each ovary, that means good ovarian reserve. If less than 4, that is poor ovarian reserve. If less than 10 in both ovaries, then also poor ovarian reserve. Okay. Then see, all the test of ovulation, all the tests that we are performing, that is preferred in day 2 of menses. What happens if the patient is having irregular cycles? In irregular cycles, we do 1 week before menstruation. See, all the tests, all tests are preferred in day 22 of menstruation. But if this is in regular cycle, that is 28 to 30 days of cycle. But if the patient is having irregular cycles, in case of irregular cycles, we perform all the test 1 week before menstruation. Okay. And one thing I forgot to tell, that serum AMH level, that is 0. If less than 0.5 nanogram per ml, that means poor ovarian reserve. Okay. Then coming to the tubal factors.